Ladies and gentlemen, welcome to another insightful episode of the Indian Journal of Anaesthesia podcast, the platform where we delve deep into the world of anesthesia, pain management, critical care, and other medical advancements. I'm your host, Murli Tondebavi, and today we have a truly special episode lined up for you. We are honored today to be joined by three distinguished editors, including the editor-in-chief from the Indian Journal of Anaesthesia, who will share their expertise and insights on various subject matters. The field of anesthesiology is vast and ever evolving, and there's no shortage of intriguing topics to explore. Rather than dissecting specific articles, we are going to explore captivating subjects inspired by the latest research in this month, that is the December 2023 edition of Indian Journal of Anaesthesia. But before we delve into our discussion, let me take a moment to introduce our esteemed guests today. Firstly, we have the editor-in-chief, Professor Rakesh Garg, from the Department of Anaesthesia, Critical Care and Pain Management and Palliative Care from All India Institute of Medical Sciences, Delhi. We are joined today by Professor Aloka Samantarai, who is the professor and the head of the Department of Anesthesiology in Sri Venkateswara Institute of Medical Sciences, Tirupati, India. And we have Professor Nishant Kumar, who is currently the professor in the Department of Anesthesiology and Critical Care at Lady Hardinge Medical College and Associated Hospitals in New Delhi, which is affiliated to the University of Delhi in India. So coming to what articles have we chosen to discuss today? So the first article that actually caught our attention was the evaluation of perioperative routine coagulation testing versus thromboelastography for major liver resection, a single-arm prospective interventional trial, also called the Portal trial, by Ambulkar et al. Now, in this trial, the study aimed at comparing the perioperative routine coagulation testing with thromboelastography for major liver resection, promising insights that could impact clinical practice. So we thought we should delve a little bit more deeper into this subject of bedside testing of coagulation, and I'm happy to have Dr. Aloka Samantarai, who's here to actually take a few questions about this. Dr. Aloka, welcome to the podcast.
Yeah, thank you, Dr. Murli, and a very good evening.
Thank you. Thanks a lot for joining us. Now, bedside testing of coagulation is something which has been in vogue for many years, in fact, a few decades. But to understand it actually can be a little bit difficult because there is so much to coagulation as a postgraduate when you read, all the factors and everything. So I just wanted to ask you, can you just explain a little bit about the importance of bedside testing of coagulation in the perioperative period?
Yeah, let me first tell you this Portal trial is a very informative trial indeed. It looks into how the anesthesiologist look at the prospects of controlling the bleeding in a patients like who is in either of the state, either it's a hypercoagulable or a hypocoagulable state. Coming to the bedside testing, or what we call a point of care testing. This is something what we do the test coagulation parameter near the patient. This is very popular and gaining more and more popularity because the first thing, if you look at it, is it avoids the pre-analytic stage error of processing the sample to the central laboratory to get a result. The other important aspects among the clinicians of the point of care testing is it provides a faster results which allow the clinician to take a decision immediately, and that actually help in a better patient outcome.
And when we talk about this bedside testing, can you just tell us what are the key coagulation parameters that an anesthesiologist should be worried about and should be monitoring bedside? Because there are a lot of tests and a lot of parameters that can be monitored. So what are the key things that anesthesiologists should be monitoring?
Yes, the anesthesiologist, apart from being worried about so many other things while looking after a case, the main thing that worries them is whether the patient is going to bleed more and how they are able to going to control the bleed or how they are going to prevent the patient bleeding. So for this, they do a set of parameter, a set of test. In the older days, they were relying on the simple bleeding time or clotting time by IV or Duke methods. But nowadays, no longer those things are recommended because they are neither sensitive nor specific. The current generation of anesthesiologists basically rely on few coagulation tests depending on the type of surgery. But the basic things that they look in the conventional coagulation parameter is something to look at the anticoagulation monitoring device like a simple prothrombin time, international normalized ratio, or activated partial thromboplatin time. Sometimes they also look at the platelet function by looking at the platelet aggregations. And the third thing that look at, which is recently also been covered in the Indian Journal of Anesthesia, what we are talking about portal tile is viscoelastic properties of the blood, that is the thromboelastogram or thromboelastometry, to look at how the kinetics of the blood clots occurs to give a proper insight into what preventive measures can be done or how to manage a perioperative bleeding.
And in your experience now, as a listener, I would like to know, in your experience, has it helped in decision making during any specific case? It could be a major surgery, a minor one, an obstetric case, a pediatric case, or even a cardiac case. Has bedside testing helped in any specific case that you can remember?
Definitely it helps. Let me first talk about a little bit about this portal tile where they have looked into the major liver resection surgery,
Yeah.
where they have found that this bedside test not only helped them in reducing the transfusion requirement, but two other things they have found which helped them to give a decision about when to remove the epidural catheter, keeping the while keeping themselves safe while looking at the guidelines currently recommended to remove the epidural catheter. For example, they have two important findings. One is they found that a baseline INR and the baseline take does not indicate how the patient is going to bleed or how to manage the perioperative bleeding in the intraoperative period. Second thing, what they found is despite having a high INR, a point of care thromboelastometry gave them additional input how to look into this bleeding. Now, coming to my experience, I have seen that in particularly in the cardiac setup, a point of care test really helps when we are trying to re-explore the patients on when we look into the diffuse bleeding in the post-operative period. Many times it could be only because of non-neutralization of the heparin what we give for cardiopulmonary bypass. This we can look from the reaction time in the thromboelastogram, and it may not require the platelet. That the common dictum is once the patient comes from a lung bypass, we feel that the patient might have consumed a lot of platelet. The platelet may be defective, platelet may not be adequate, whether to give FAP or to give protamine. So that type of doubt usually you can eliminate by looking into this thromboelastogram. Sometimes simple additional dose of protamine may help in neutralizing the heparin and the diffusing will come down. Sometimes we need to give the FAP, and sometimes looking at the thromboelastogram trace of the maximum amplitude, we need to give the platelet. Many a time, everything may be normal. We may have to give a simple antifibrinolytic drugs to look at if the clot lysis is very much more compared to what is there in the reference range. You can just give a antifibrinolytic like tranexamic acids to get control over the bleeding, and this definitely has a good outcome on the total patient management.
Yeah, you mentioned a lot of benefits now as to what we can use it for. But in your experience and also taking into the perspective that in a country like India, which has got so much of variations in the amount of equipment available, the kind of practices that are there, what are the specific challenges or limitations that we should keep in mind, especially when we are talking about this bedside testing?
One major challenge is in a country like India is availability of the instrument. even in certain tertiary care setup, you may have a single instrument which is instead of being there in the operation theater or in the critical care arena, it may be in a laboratory, it may not be in a central laboratory, it may be in the blood bank or some other areas where we need to give a processed blood again to them. But this thing can be overcome sometime if you have a particular person designated for carrying out the blood sample immediately to the thromboelastometry. Probably you don't need a process sample. Second thing is the thromboelastometry will not able to give you a proper value unless few basic parameters which cause this type of coagulopathy or bleeding is not taken care of. Like a patient who is hypothermic, whose ionized calcium is less. These people, unless this part was, our patient is in acidosis, unless this part was taken care of, just treating the parameters of thromboelastogram will not be sufficient. So one, while ordering a thromboelastogram, one should also look into these basic parameters which causes bleeding so that this type of bleeding problem can be managed in a wholesome way.
Thanks a lot for your insights, Professor. Now, it is something which is dear to many of them, especially when they do obstetrics or cardiac or major surgeries like liver resection and transplants. And you have actually provided insights in a very clear and precise manner as to how to go about doing the perioperative bedside coagulation testing. Thank you. Thanks a lot for joining us.
Thank you. Thank you, Dr. Murli.
Thank you. So next, moving to another important topic. For all chest wall surgeries, thoracic epidural was a gold standard a decade or 15 years ago. But since the introduction of ultrasound and the regional anesthesia, which is becoming more popular, we are seeing a lot of chest wall blocks. And in this month's December 23 edition of Indian Journal of Anesthesia, we have had two articles in this regard. The first one being the efficacy of serratus posterior superior intercostal plane block on post-operative pain and total analgesic consumption in patients undergoing video-assisted thoracoscopic surgery, that is VATS, by Dr. Avsi et al. And we have also had another paper which shows a comparison of ultrasound-guided paravertebral block versus erector spinae block for post-operative analgesia after percutaneous nephrolithotomy. This was a randomized double-blind control study by Court et al. And both of them were looking at the blocks to improve the post-operative analgesia. And to discuss this subject of chest wall blocks, I have with us Professor Nishant Kumar, who is, as introduced earlier, from Lady Hardinge Medical College, Delhi. Warm welcome to you, Professor.
Good evening, Dr. Murli. Thank you for having me here.
Good evening, good evening. So to just start off this discussion, we are seeing so much of popularity in chest wall blocks, and there's been a revolution with the kind of facial plane blocks, especially in the chest wall area. Now, in your anesthetic practice, what would you say are the indications for these chest wall blocks, and how have they contributed to patient care?
So basically, as the name suggests, the chest wall blocks are meant for any patient who's having any surgery on the chest wall, be it the anterior chest wall or the back. So as you have rightly said, the gold standard still is the thoracic epidural, but then we know that for unilateral surgeries, the epidural spread has hemodynamic side effects, which may be undesirable in certain population, the geriatric, those who are hemodynamically unstable, and also to a certain extent, the epidural is still a blind technique. And we all know that the thoracic epidural is one of the toughest epidurals that can be given. So with the advent of ultrasound, and there are about 40 odd blocks described with various terminologies, but in 2021, with the Delphi consensus, these terminologies have been reduced to 20, making our life easier. So in other words, there are about 20 blocks described for the thoracic cavity, posterior, anterior, lateral. So any part of the chest and the back, which any surgery, be it a minor surgery such as a lipoma removal, it can be for laminectomies, it can be for thoracotomies, nephrolithotomies, in fact, MRMs. So any surgery on the chest and the back can be covered with these blocks. And definitely, as we all know, the advantages of regional anesthesia, lesser depth is required. Then you have opioid sparing effect on chronic pain. And obviously, you require a good pain relief in the post-operative period for these surgeries. Why? Because your thorax is constantly moving with respiration. So thoracic surgery, especially the thoracotomies, have been described as the most painful surgeries that a person can undergo.
Yeah, I agree with you with this, especially the epidural failure rate. Now, the recent articles which are coming out this year also have shown that the rate can be as high as 25 to 30%. And going with the chest wall blocks, again, I agree with you very much that the nomenclature is very confusing. And the Delphi consensus, which came out in 21 actually simplified the matters a little bit. Can you just highlight a little bit about how it has simplified from 40 odd blocks, which were earlier described, to 20 now?
See, basically the blocks, these are all plain blocks. They have been divided into the paraspinal blocks and the plain blocks. And the terminology is now based on exactly where we are depositing the local anesthetic. So, for example, we used to have, if we see the nomenclature for rhomboid intercostal plain block, which is not very different from the SPS IPV we described in this issue. So this is just a layer above. So the earlier terminology was rhomboid intercostal subserratus plain block or rhomboid intercostal plain block. Now these two terminologies were being used for the same block. The drug is deposited in the same plane. So now it has been changed to rhomboid intercostal plain block. So like this, many other blocks have been clubbed into the anatomical position where exactly the drug is being deposited, or the exact anatomical landmarks where your needle lies. So that has made simplified, and this is much more clearer where exactly we are giving the block.
Yeah, I think for our listeners, for the benefit of especially the trainees who are listening to this podcast, we would strongly urge them to go through this paper, which came out in 2021, which talks about nomenclature. And as you said, the PEC1 and PEC2 blocks again have been now renamed as pectopectoral. So
yeah,
I think the trainees probably will benefit from this. But coming to your practice, what are the challenges that you're seeing or complications that you might have come across either by anecdotal experience or in your personal experience when we do the chest wall blocks?
So the most common complication, or rather I would not say it as a complication. The most common side effect is the failure of the block, because normally we don't deposit the drug where it is intended to deposit. That comes with practice. A good ultrasound image is required. For that, again, practice is required. But then, personally speaking, the complications rate for these blocks is fairly low, and mainly for the anterior chest wall blocks and the paraspinal blocks when you're close to the pleura. So one of the major complications lies is the pneumothorax. But if you've got your sonoanatomy correct, if you're visualizing the pleura, you're watching the lung sliding, so the side effects are practically minimal. One odd hematoma if you miss the vessels. But then if you're careful enough, you just put in a Doppler once or a color once, and you see that there's no vessel in your needle path. In fact, even in patients with mildly deranged coagulation parameters, as has been talked earlier, these blocks are considered fairly safe. Although not the continuous technique, but single shot, when done under expertise and under vision with ultrasound, these have been considered fairly safe. So one of the problems for the anterior chest blocks is that sometimes the surgeons do complain because we have to deposit a lot of volume in the planes. So sometimes the planes get distorted and the surgeons may not be happy. So you can always go and block away from the incision site or the dissection plane. So that would minimize the acceptability of the surgeons. So that will increase acceptability of the surgeons to these blocks as well.
Yeah, I very much agree with you, because that is one of the key complaints, especially if a surgeon is not used to the anesthetist practicing these blocks in his practice. But another important thing which I wanted to highlight was also the dosage of the local anesthetic, because these being facial plain blocks, I think listeners who are listening to this need to be a bit watchful, especially with the amount of drug used. Do you agree with me on this?
So basically now when we are using these blocks are mainly used for the analgesia. So by reducing the concentration to 0.25% or 0.125% or using ropivacaine 0.2%, so we can increase the volume. All these blocks are volume based. As you rightly said, all these blocks are volume based, but then most of the drugs stay in the interfacial plane where the absorption is not much. But yes, you have to be mindful about the toxic dosages and follow the guidelines so as to prevent last, which is obviously it can be life-threatening and devastating. So you're very correct that you have to keep a watch on the dosage. But yes, as I said earlier also, that better to avoid mixture of the local anesthetics as was practiced in the past. Now we are moving towards a single agent. We can add additives to these local anesthetics. Again, there's a list of do's and don'ts. Many of these are rampant in the clinical practice, but not FDA or DCGI approved. But yes, there are certain drugs which we can use and prolong the effect. And definitely by using sub-anesthetic or rather analgesic concentrations and limiting the volumes, because we are giving it under vision. So that will help prevent the toxicity and dangers of toxicity and last.
Yeah, thanks a lot for your insights, Dr. Nishant. I think we will definitely see more of these chest wall blocks coming into practice, especially with ERAS protocols becoming a common practice. Thank you very much.
Thank you, Dr. Moon. Thanks a lot.
So finally, I would like to invite Professor Rakesh Garg to discuss a little bit about one of the articles which came out in this month edition, which is a systematic review and quality analysis of cancer pain guidelines by Thota et al. Professor Garg, how do you stay updated on the latest advancements and changes in this pain management guidelines? That's something which is on everybody's mind because there are so many guidelines coming out.
Thank you, Dr. Modi Thandavi, to take this important session where we are looking into the nitty-gritties of various academics and research. So when we talk about how do we choose it, we have so many things into our basket and we have to choose the correct one. And say, if you see this article, even they have tried to look for 14 guidelines which has come from various professional societies. And they have been thought to be very well formulated and released. But everything, say medical science is a very, lot of things comes up, they need revision, they need modification. Nowadays, we are talking about the live guidelines also, because when something comes new up, they should be modified and revised because a lot of literature is coming up. So how to choose from that basket is that we need to look into our practice. If you remember about the evidence-based medicine, there are three pillars. One, obviously, we talk about the published literature, but we also talk about our own need and the population that we are catering it, the need they have, the infrastructure that we have, expertise that we have, and we need to integrate into our selection of the published guidelines that we have. But on the other hand, I think we will leave it to the academician or the editors or sometimes the researchers also, that how to look for the quality of these guidelines. And there are certain parameters for it. And that's why we say in a very technical language as the critical appraisal of a published paper. So when we say that the publication is not only for researchers, it is also for clinicians, because they should understand that whatever is being published, they need to critical appraise it before they can bring into their practice. And this becomes very important. Once you select from the basket the most suitable guideline, which is of good quality, updated to the latest research, and it fits into your clinical practice, I think that's the best thing. And how can you stay updated? I think as the editor chief of IJA, I'll say keep in touch with the IJA, and you will get most of the recent things updated. But yes, other journals also look for, they are also publishing good articles. So just spend some time looking for them, reading for them, so that you remain updated.
Thanks a lot. That was a really a wonderful way to put it. Now, individualized pain management plan. You said you need to know the guidelines. You need to incorporate it into your local practice. Where does the role of audit or looking into one's practice come? Because quality is again based on the patient's outcome rather than just following a guideline. So, do you have anything to say on this?
Absolutely. I think Dr. Murli Thondavi, you have raised a very important question. What we do needs to have its implication on the patient outcome. If you see the studies, the research which is going on, I think this is a message for all the researchers also. We were looking for very small outcomes like the numerical rating scale or visual analog scale decreasing by 3 points from 7 to 5, and that was the outcome of the research. And we are looking for the 3 VAS or NRS out of 10. This were we looking for. But finally, what exactly we are looking for is not the numerical rating scale, because the perception may be different. What we are looking for is impact on the patient. And that's why if you see these guidelines also, and this nice systematic review in December issue of 23 of IJA, we talked about the impact on quality of the patient, and that's the crux. And that requires audit. Say, for example, I am doing, say, multimodal management. I am little pro for intervention, or I am little pro for pharmacological management. Okay, it's fine that the NRS may be decreasing by 3 points. My majority of patients will be 3 or 4. But I need to audit myself that after taking care of, say, 50 patients, 100 patients in a month, whether I am really impacting their quality of life. Are they going back to do their normal work? Are they going back to the society and are able to be at par with their other peers? This is what we should be looking for when we talk about the audit system. If it is lacuna, this means what I am doing is probably needs to be changed, and that needs to be explored into the population. And based on this, I can pick some guidelines which is suitable for them. I can change my practice. I can learn something. I can make a team. And this is what sometimes we use a word, something called precision medicine, or some people say is a tailor-made prescription or an individualized medicine. You will have some crux in the next issue, January issue of 24. I'm not releasing that suspense, but let's talk about these things when we talk about the holistic pain management.
Thanks a lot, Dr. Garg. It's been a wonderful, insightful, last 15, 20 minutes with all three of you. And that actually brings us to the end of another enriching episode of the podcast of Indian Journal of Anaesthesia with the editors. And heartfelt thanks to all three of you for joining this evening and for sharing your valuable insights. And also, I would like to thank all the listeners who have spent their precious 15, 20 minutes listening to us, and hope you have found this discussion informative and captivating as much as I did. And be sure to, subscribe to our podcast so that you hear more engaging conversations in the future, and you will stay updated in the latest with what's happening in the world of anesthesia. So until next time, this is Murli here, signing off. Stay curious, stay informed, and most importantly, take care of yourself. Wishing you all a happy new year, and hope to see you in the next year with much more exciting episodes. Thank you very much.